fluorescence. So we will be, I will try to be brief and simple. That's the only one thing which I can say that I'll try. We know that the management of the treatment, all these viruses, since morning we are hearing that that leads to liver fibrosis, cirrhosis, and HCC, and then you need liver transplant to help these people. But can we treat these patients? Can we avoid them? And even if we are going for liver transplant, how we can manage these patients before, during, and later on. So for HBV, we know that in the pre-liver transplant HBV management, we know that antiviral treatment is necessary for all patients diagnosed with advanced fibrosis, cirrhosis, and decompensated cirrhosis. So whether the F4 fibrosis onwards, even if the HBV DNA is negative, you should treat them. We also know that prolonged treatment will lead to islet suppression, leading to regression of advanced fibrosis and even cirrhosis at times. Treatment with nucleoside analogs has shown survival benefits. And for patients waiting for liver transplant, you should treat these patients because to keep them stable and prevent worsening. We also, Dr. Faruqi referred to this, 0.5 milligram per day is the routine dose, but 1 milligram dose is preferred, and specifically in the decompensated liver disease, or if the patient has previously used lamivudine. We also know that with the availability of the staph, it is preferred over the TDF as it is more concentrated in the intrahepatic concentration or more, and it is a favorable side effect profile. So when we treat these patients pre-liver transplant, we know that, and why we treat them, that there is a direct correlation between the HBV DNA levels at the time of liver transplant and the rate of recurrence. We know this is a known fact. And also, HBV treatment along with post-transplant prophylaxis has resulted in HBV recurrence rates from almost 100% to less than 10%. We know that before the advent of this lamivudine and the combination of lamivudine and HBV, it was almost like people stopped sort of doing liver transplantation for these patients almost, because they would have it. And since the lamivudine and combination of lamivudine with HBV changed the indication, or the liver transplant has become now routine. Is combination of nucleoside, nucleotide beneficial? We know that sometimes you need to rapidly control and have a decline in the HBV DNA levels, specifically in ACLF, and if the pre-liver transplant HBV DNA is high. So at times one may combine even entecavir with tenofovir for that matter. And this also helps not only that the viral DNA levels would go down, but at the same time they lead to decrease in the risk of recurrence, as we know that the level of DNA is associated with the recurrence. In ALF, you should start promptly. As soon as there is an hepatitis B core IgM positive or hepatitis B surface antigen positive, send the DNA level, start these patients, and preferably on 1 milligram in acute severe hepatitis B or in ALF. Do not delay liver transplant for the nucleoside analogs to work. So you can proceed with whenever the patient needs a liver transplant, because the timing is also crucial, but you should start treatment promptly. Peri-liver transplant HBV management, the intravenous HBV is given in the N-hepatic phase. We know that in standard practice, the usual dose is 2,000 to 10,000, the more the better. And it is followed by the IV or IM HBV in the post-transplant period. Not always and not practiced by all centers. We will come to that in a while. Of course, you will continue with the nucleotide analogs, whichever you are giving. Now, the HBV recurrence after liver transplant. We know there are two things. One, the moment you put the liver in and remove the clamps from the IVC and the reverse perfusion occurs to the liver, that's the time of infection. So HBV neutralizes the HBV DNA hepatitis B virus in the blood, and it neutralizes there. So to prevent infection of the graft, you need HBIG. To prevent inflammation, which is hepatitis, flare, or reactivation of the hepatitis B virus, because that is present somewhere, you need nucleoside-nucleotide analogs. So there are two things. How do we define recurrence? It is reappearance of either hepatitis B surface antigen or detectable HBV DNA, or both. We will come to that, why we are saying that or detectable HBV DNA, because one can have detectable HBV DNA levels even in the absence of hepatitis B surface antigen positive post-transplant. HBV DNA checking is essential even if HBV is negative, because the S mutations may occur, and this is more true when you're using these medications, like the combination of HBIG with the nucleoside analogs. The mechanism of HBV recurrence after transplant includes how it occurs. Like there is high viral loads, and there is saturation of the HBIG by the high viral load. So there are some viruses which are not neutralized. And then there is emergence of antibody-induced escape HBV mutants, and mutation in the hepatitis B surface antigen, surface antibody escape mutations would occur, and that's how you need to check for the hepatitis B viral DNA as well, not only hepatitis B surface antigen. How they present? The recurrence present as an either acute hepatitis or chronic hepatitis. There will be deranged LFTs, or chronic hepatitis, there will be some fibrosis along with that if it's more than 6 months. And it may even present as an ALF, as acute liver failure, or the sinister of all these is also, along with the ALF, is the fibrosing cholestatic hepatitis may present like that. So who are at risk for recurrence? So we know that for sure that hepatitis B E antigen positive patients, because we know that they have got high viral loads, and HBV negative status, HBe antigen negative status with the high DNA presence, or if there are nucleoside analogs or nucleotide analog resistance species, the RAS are present. So they are also predictive of the recurrence. Recurrence rate at 5 years was 15% in E antigen positive, while it was a bit lower if the E antigen is lower, because you know that the viral load is usually low in HBV antigen negative status. The presence of HCC also contributes, and HCC recurrence after liver transplant also affect HBV recurrence. So these patients are at more risk if they have got an HCC. Now, how to prevent HBV recurrence? So we use the HBIG, and we use nucleoside-nucleotide analogs, and of course, combination is always better. So we can use both at the same time. We will come to that, how to use them judiciously. Despite removal of the liver, because we know that the whole of the main burden of hepatitis B is in the liver, the cccDNA, the genome, everything is there. So if you remove the liver, the burden is removed, but still there are extra hepatic sites, such as lymph nodes, spleen, and other organs. They would have they would have this hepatitis B, and this latent virus gets reactivated because of the immunosuppression regimen after liver transplant. And that's why these patients are kept on nucleoside-nucleotide analogs lifelong. Now, we know that HBIG is a polyclonal antibodies, blocks receptor involved in the exportation of the viruses from the extrahepatic site, along with the formation of immune complexes, and result in neutralization of the viral particle. They are good in short term, but may not be in the long term, because they're expensive, not readily available. It's an indefinite therapy, and of course, one may develop HBIG resistant mutations. They're not that freely available even at times, and they're expensive. Nucleoside monotherapy with lamivudine and adefovir were effective in reducing HBV recurrence. However, there were issues in the long term, as they have got low genetic barrier to resistance. We don't use these two drugs nowadays. Entecavir, as it has high genetic barriers to resistance, the recurrence happened in 16% at 8 years. So it was like a good drug for that matter. And HBs antigen positive patients with monotherapy were 10% at 2 years of follow-up. So it's around, so even at times you may use if the HBIG is not available, or there's financial constraints, and we will come to that when we can make sort of this decision. Now, this is if you look at this study from the Subhash Gupta's group with Manav, so it was like the patients with HBV DNA level less than 2,000, they were not given HBIG. We are talking about HBIG later on. All of these patients would receive HBIG during the N-hepatic phase. And patients with HBV DNA level more than 2,000 were given HBIG, and recurrence was defined by the HBV DNA positivity at six months. So they concluded that HBIG prophylaxis with oral antivirals and without HBIG is safe, effective, in the living donor-related liver transplant, and a majority of patients will clear HBs antigen and may even develop antibodies. So, and the patients were, the number was small, and then it was followed by another study. We'll come to that in a while, but I think probably we missed that, or what? No. So the combination therapy which HBIG with nucleoside is associated with very low recurrence rates after liver transplant, and several large meta-analyses have shown that combination therapy is associated with reduced HBV mortality compared to HBIG alone. Now, what they used was, this is a study from the Australia and New Zealand, Peter Angus, and this was limivudine plus low dose 400 or 800 intramuscular HBIG were used weekly from transplantation and then monthly thereafter, and they concluded that the limivudine and low dose HBIG treatment prevents post-liver transplant recurrence of hepatitis B and is likely to be more cost-effective than the high-dose HBIG regimens. And then it's followed by this Gans paper, and then they used, it was a large study, and the low-dose intramuscular HBIG plus limivudine provides safe and effective long-term prophylaxis against recurrent HBV and less than 10% of the at less than 10% of the cost of high-dose regimen. And if you look at there, the recurrence rate was 1% at 1 year and 4% at 5 years, so pretty much acceptable. This study from the India again by the Soin group, and they had a pretty large number, and what they did was all the patients received 10,000 international units and N-hepatic phase, and then followed by 600 to 1,000 intramuscular for 7 days, and then weekly for 3 weeks, and then monthly. And they tried to keep the hepatitis B surface antibodies more than 100 for 1 year. And then they look for the recurrence. And only 2 patients had, one was non-compliant and the other had a proper recurrence. So out of the 43 mean follow-up months in 43 months, or from some up to even 117 months, they had some patients, because this was a long study. And they concluded that this enlarged cohort of the living donor liver transplant recipient HBV-related liver disease, use of low-dose short-term HBIG with given high genetic barrier. They used entecavir in this study, so this was a good one, in a substantial lower incidence of HBV recurrence, and even in high-risk patients, those who had more than 2,000 HBV DNA. Now, only nukes alone or with HBIG, many institutions are now shifting towards HBIG-free regimens in patients to be who are at low risk of recurrence of infection, or discontinuing HBIG after a short period of time. And if you look at all these studies, so if you look at the last one, it used only HBIG for 7 days, some for 6 months or 9 months, and up to a year. And they had a pretty low HBV recurrence rates. So with combination of HBIG, specifically low HBIG, later on after the N-hepatic phase, along with the nucleoside analog, specifically the entecavir or tenofovir, one can manage these patients better. Can hepatitis B core antibodies, like those who had past exposure, grafts can be accepted for liver transplant? Yes, why not? Because large liver grafts from anti-HBC donors can be safely used, and we do use them because up to 40% of the grafts from the Sindh area would be having past exposure, and they are hepatitis B core antibodies positive. Preferentially, they should be used in the hepatitis B surface antigen, but we do use them otherwise as well. Of course, in these patients, you don't give them HBIG. As we mentioned, HBIG only prevents the infection. They have already got the liver, which has got a DNA inside the genome and CCC DNA. So you don't give them an HBIG. But of course, lifelong prophylaxis with nucleotide analogs is given. HBV treatment summary: compensated decompensated cirrhosis, start them on high genetic barrier nucleoside analog. Improvement, of course, you continue with them. Transplant indication: once decompensation occurs, RECC is there, you give them, you transplant them, and lifelong high genetic barrier nucleoside analogs are given. Considering HBIG also in patients, specifically those are high risk for HBV recurrence, like they have got RAS or high HBV DNA at time of transplant, or if they have got co-infection or they have got HCC. Moving on to the HCV, we know that HCV infection recurs in all patients with HCV viremic patients at the time of, if they have got, at the time of transplantation, if the HCV viremia is there, so they would have a recurrence. Difficult to differentiate between, at times, between the T-cell mediated rejection and HCV infections, and be mindful of one thing: this fibrosing cholestatic hepatitis C may occur after liver transplant, though it's rare, but still you should be watching for it and needs treatment early and promptly. In the pre-DAs era, SVR rates were poor even when we would treat these patients. But however, with the DAs, now we have got up to 90% of the SVR rates. Suboptimal SVR and tolerability were main issues. We know that for sure before the DAs, the availability of DAs leads to remarkable improvement in SVR rates. And HCV treatment, we also know that if you can achieve SVR, it will translate into all-cause mortality as well as reduced liver-related mortality. So treat them if you can. Now, these data demonstrate an association between the DAs and reducing listing rate for HCV-related cirrhosis and HCC. So DAs have changed the scenario. So treat them if you can, and treat them before advanced fibrosis. That's why we say that Dr. Asad was referring to that, find the missing millions, and we should test, screen, and then treat. Now, delisting can delisting occur? Yes, why not? The study showed that all oral DAs were able to reverse liver dysfunctions and favored the inactivation or delisting of about 1 in 3 or 1 in 5 in 60 weeks respectively. And patients with lower MELD scores had higher chances to be delisted. And this study questioned that whether in the long term it will help or not, but in the short term it concluded that it helps. And then the answer came from this study that DAs are safe and effective in patients awaiting liver transplant for cirrhosis and HCC, and a quarter of patients with cirrhosis can be delisted because of clinical improvement. And the dropout rate was over 6.7%, and few recurrences of HCC even after liver transplant were observed. So you need to treat and treat if you can. When to treat and when not to treat, everybody knows that MELD score beyond 27, do not treat. Even in USA, some centers, because of the different UNOS regions, 23 MELD is the cutoff. So these findings suggest that optimal MELD threshold below which decompensated cirrhosis should receive treatment while awaiting liver transplant is somewhere between 23 and 27, depending on the UNOS regions. But if the patient is less than 23, must consider treatment, okay? Specifically if the waiting listing time is more. Now, the categorization by the MELD score, the DA therapy is a systematic review. Decompensated patients must be personalized when considering different factors, particularly the MELD score is more than 18 or 18. So less than 17, definitely treat them. Is this treatment cost effective? And at what MELD it's cost effective? So if the MELD score is 20 or low, it's cost effective. However, post-liver transplant treatment is cost effective if the MELD score is more than 20. However, personalized approach and expert help is recommended in all these patients. Decompensation can occur, so please be careful. Now, Word of caution regarding while using protease inhibitor, luckily we don't have them, but still not in decompensated and even in child B cirrhosis. Now, they also say that RAS testing, if not available in cirrhosis, add ribavirin. So ribavirin is a very good drug. Wherever you can use it in advanced fibrosis, cirrhosis, or decompensated cirrhosis, please use it. But we don't have the RAS, so by default, we should use it. Treatment naive genotype 3 with compensated cirrhosis, if we don't go for the RAS testing because we don't have it, so you can have it either prolong the treatment durations or add ribavirin. And daily fixed dose of the other medications which are not available to us can be used for 8 weeks as well. Treatment failures with and or without compensated cirrhosis, so then you need to go to the, add another one to it, which is voxiliprevir, and it's for 12 weeks. Alternative is the one with the glicaprevir and pebrentasvir, but it will be then 16 weeks if they have got previously DAS failures, like soft failure. Decompensated cirrhosis, recommended in all patients with HCV who have decompensated cirrhosis, you should be at least, if there is moderate or severe hepatic impairment, should be referred to a medical practitioner with expertise in that condition, and ideally to the liver transplant center. And they should be then deciding whether to treat them or not. So patients with decompensated cirrhosis who have genotype 1 to 6 are ribavirin eligible, add it 12 weeks. Even you can use the other ledipasvir and sofosbuvir in non-genotype 3 and 2 patients. Patients with decompensated cirrhosis who have genotype 1 to 6 and are ribavirin ineligible, extended duration to 24 weeks. When to stop? If there is a increase in the ALT level, specifically the sign is wrong, is more than 10 folds, and there are signs or symptoms, stop treatment. Specifically, if the alkaline phosphatase is high, bilirubin is high, and IR is going up, or there is any signs of jaundice or decompensation, please stop treatment. And asymptomatic patients with the high ALT level, monitor them at 2 weeks interval, and if the level remains persistently elevated, consider stopping treatment. HCV treatment post liver transplant, a meta-analysis of 22 studies with good number of patients. SVR12 was almost 90%, and SVR was higher in patients with mild fibrosis when compared to advanced fibrosis cirrhosis. So treat them early post-transplant. These 2 studies from India, they almost had 89 to 93% SVR rates, and they, somehow or other in their studies, the SVR rates for genotype 1 and 3 were similar. Post-liver transplant HCV treatment, naive and experienced patient with genotype 1 to 6 infections of the allograft without cirrhosis, again, treat them as patients like before 12 weeks of the whatever is available to us, which is sofosbuvir, vilpetasvir, or the other one is the glicaprevir and pebrentasvir. Experienced patients with genotype 1 to 6 infection of the allograft compensated cirrhosis, then you can use the same, even if they have been treated previously, you can use the same combination and duration with either sofosbuvir, vilpetasvir, or the other available to, which are not available to us. Now, can we have a HCV positive donor and to an HCV negative recipient? That's a question. Not in a living donor liver transplant, okay? So we do not, would not like to have a liver from a HCV positive living donor. So far we are not brave enough, maybe sometimes, but not yet. But these are in the DDLT things. And they would recommend early treatment with pan-genotypic DAS is recommended when the patient is clinically stable. And Again, the durations and the regimen as there is the soft plus well for 12 weeks. Now, timing of the HCV treatment post-liver transplant, once patient is stable and steady immunosuppression is achieved, you can start treatment. Optimal timing is not clear. However, 3 months seems to be reasonable because by that time, and specifically, you need to document the HCV viremia. Treatment may be started even before 3 months if the patient is stable, and treatment should not be delayed, and specifically in fibrosing cholestatic hepatitis C. Some interactions for us, simple to remember, the soft plus well, they are okay with all the both the CNIs which we use normally. So, of course, there are some data is not available for the TEC and with velpatasvir, but it's okay. You can use it, and we are using it. HCV treatment summary: compensated cirrhosis, non-genotype 3 and genotype 3. We know 12 weeks. If there is a genotype 3, add ribavirin. If ineligible, then extended durations. After liver transplantation, is 12 weeks therapy. HCV treatment summary: HCV-related decompensated cirrhosis, look for HCC. If HCC is there, go for transplantation. If I'm saying decompensated cirrhosis, okay? And compensated, you can think of other things, because to treat the HCC, and then once HCC is controlled, one may still think of a pre-liver transplant HCV treatment. If no HCC, MELD is 18 to 20 or more, defer treatment after liver transplant. If it is less than 18 or 20, you can go for the treatment. And we know that how to treat these patients, either 12 weeks or 24 weeks. I would thank you all for your kind listening, and would like to take this opportunity to announce that the 42nd Annual Congress of the Pakistan Society of Gastroenterology will be on April 10 to 12, 2026, and it will be at the PC Bourbon, inshallah.